Yes, thank you. He is head clinical unit emergency department from South Africa, and he's going to tell us something about pain and analgesia in emergency medicine. Thank you.
Thank you very much. And just on the outset, a big thank you to the organizers, the sponsors, and to EPAT for this fantastic conference and the kind invitation. Just with regards to this talk, I have no declarations to make other than the fact that I do manage pain. I have pain at times, and I like to have my pain managed at times as well. So let's start off. We are physicians. We are the masters of our craft, and we are there to create amazing things for our patients. I'm a savior of the universe, or so I think. Is everyone awake now? Now, is that when I'm providing that savior of the universe role to the patients, I do the best of my ability. And I do it in a facility that is equipped to do that. But in emergency medicine, we need to balance that off with the kinds of pressures that we are working under. And the patients keep coming and keep coming and keep coming. And some of them come by ambulance, some of them come by helicopters, but a large number of those patients form these huge queues outside of our doors. And so we're needing to have an approach that is feasible within our resource constraints and ensure that we are able to provide an adequate level of analgesia to the patients presenting to our departments. Now, I think we've all had this. I think he needs analgesia.
Shall we, Jane? Pain. I see a red door and now it's mirror just seems hit.
Something that she says in that clip is something that we say to our patients on a daily basis. This is going to hurt a bit. It may be when we're putting in an intravenous access, it may be when we are trying to manipulate a fracture, but it's going to hurt. And we need to have an understanding about what that pain is. Now, pain was defined a long time ago as being pain of acute onset, probable of limited duration, and usually can have an identifiable source, whether that identifiable source is temporal or has a causal relationship to injury or disease. Now, in 2020, there was a revised definition of pain. And I'm going to read that because it has changed our understanding quite a bit. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And this definition really reflects the complexities of what we are dealing with when we are dealing with an individual's experience, both on a psychosocial level as well as on a physiological level. Now, acute pain is common in the emergency department. And there's been many guidelines that have been published, initially in the post-operative sphere and then into the palliative care sphere. But it's only recently that emergency medicine has come on board with actually having dedicated guidelines with regards to acute pain management in emergency medicine. Now, unfortunately, we tend to be a little authoritative as clinicians, particularly when we are dealing with pain. We decide when a patient has pain. We decide how severe that pain is. And that becomes a problem. Because if you're anything like me, I tend to use the ooh factor. Now, when you look at an injury and you go, ooh, or you go, eh, or, oh, and then we administer analgesia appropriately. But we know that physicians deciding on how much analgesia a patient should get is an underestimate by about 50%. And that's obviously no good. A 1 in 2 chance of getting it right when we are trying to decide how much pain a patient has on the first hand, and secondly, how much analgesia that patient should get. And so we do need to have an approach to the assessment of pain. And that would include things like a clinical examination, taking a history from the patient, taking a specific pain history, and then looking at all of the other factors that come in, the behavioral factors, environmental, social, cultural. There are many things that we need to take into account. But let's just take a step back for a moment and understand a little bit about the types of pain that our patients often face. And we can divide it up into 2 broad categories, the first being nociceptive pain. And this encompasses both somatic pain and visceral pain. Somatic pain is often described as being sharp, hot, stinging, well localized, and also associated with local or surrounding lesions. Visceral pain, on the other hand, is often dull, can be cramping or colicky, usually poorly localized, and is sometimes associated with somatic symptoms like nausea, sweating, and cardiovascular changes. Neuropathic pain, on the other hand, is pain that is caused by a lesion or disease of the somatosensory system. So here we're not looking at direct damage to the area, but it can arise following injury and disease. And it's usually when you have damage to the nerves themselves or parts of the central nervous system. For completeness, I do want to mention a third category, and that being the nociplastic pain. And it's really that other group that we can't fit or pigeonhole all of the pain types into. And it's the best example here is fibromyalgia. We get significant pain from fibromyalgia, but we are not able to put it into either of the 2 previous categories. The next point that I'd like to address is that grading of pain, something that we are terribly poor at. Now, there are many systems that have been developed with regards to the grading of pain. You'll notice that the top 3 there, the visual analog scale, the verbal rating scale, and pictorial scales are probably those that are used the most across the assessment of pain. The benefit with these is that they are not dependent on a patient's ability to read necessarily, and that can be problematic in some areas. And also it allows the patient to participate in that assessment of pain. This is one that we use quite a bit in the department that I work in that it encompasses all 3 at the same time. So you've got that visual analog scale, so looking at the happy face or the unhappy face, looking at that broad classification into no pain up to the worst pain, and then that verbal scale of saying if 10 is the worst pain you've ever had, how do you grade this pain at the moment? So let's now look at that concept of the how-to. So how do we give analgesia? And the WHO brought this out many years ago, but it was really addressed at the palliative care scenario and the management of pain in palliative care. However, in 2022, this was expanded into the management of acute pain. And what it looks at is that combination of looking at the time factor, so